webinar series. I'm Dr. Jasmine Brown, naturopathic doctor and labs medical program manager here at Fullscript, and I'm so glad to have you join us today. The focus of this webinar series is vascular and endothelial health. In today's first session, we'll discover how combining traditional and advanced biomarkers in the Metabolic Risk Panel helps clinicians catch metabolic and cardiovascular risk early. Leading today's session, French, a senior clinical consultant with over 20 years of experience in laboratory and diagnostic industry. His expertise focuses on cardiometabolic disease, particularly lipoproteins, inflammation, oxidative stress, and endothelial dysfunction. Mr. French has lectured extensively in the US and internationally on comprehensive lipid and lipoprotein testing for cardiovascular disease risk assessment. He has spoken at major conferences, including the FDA, the American College of Cardiology, the Centers for Medicare and Medicaid Services, and the National Lipid Association. Dedicated to bridging the gap between advanced diagnostics and frontline clinicians, he is committed to improving cardiovascular disease management through innovative testing. Before we get started, a few quick housekeeping notes. Please submit your questions in the chat, and we'll address as many as possible after the presentation. This webinar is being recorded, and the recording will be sent to all attendees and registrants via email. You can also access it at fullscript.com/webinars in a couple of days. A copy of the presentation slides is available for download in the file section of the platform. And there will be a 5-minute break between each session, so feel free to stretch, grab a drink, jot down some notes, or go into your Fullscript account and favorite the test for easy access in clinic. Thank you again for joining us today. Take it away, Kenneth.
All right. Thank you, Dr. Brown. I appreciate that introduction, and it's really good to be with you all. As a full disclaimer, I am an Quest employee for Quest Diagnostics. We're one of the national laboratories that draws blood and reports out results all across the country. But I want to use that to your advantage. One of the things I need to make sure that we recognize as we get into this is any and all laboratories that you work with, you need to be asking your laboratories for more information. For example, at Quest, within 1 year, we'll see about a third of the U.S. population. And if we go back, 2 to 3 years, we see about 80% of the entire U.S. adult population. So we're seeing trends that are happening in real time that won't be published in the peer-reviewed literature for another 12 to 18 months. Lean on us as a laboratory. Lean on us to understand where these things are going. Because when we get into this and we talk about, well, what's the current issues that we have with regards to cardiovascular, diabetes, non-alcoholic fatty liver disease, kidney disease, all these different comorbidities, do we see similarities? Do we see where these disease states are actually intersecting? And the answer is yes. So what I wanted to at least do is share with you some of this information you already know, but I want you to pay very close attention to some of the smaller details. So of course, within about 4 years, unfortunately, half the U.S. population will have a BMI of greater than 30 plus. So we're heading to a very complicated area, and that carries with it significant cost. Now, what I want you to also recognize is on the right-hand side of the screen is, don't judge it. Just kind of get a feel for where this is. So in the 1980s and 1990s, there was a big push for smoking cessation, and we saw a benefit in that in both men and women in their cardiovascular mortality. And then, of course, in 2000, the National Cholesterol Education Program Adult Treatment Panel 3 guidelines were released. And essentially, that was the first guideline that said we need to be a little more aggressive at managing cholesterol levels in our population because cardiovascular disease in both men and women is skyrocketing. So as a result of those guidelines, we saw, of course, a very targeted approach at trying to lower at a population level the amount of LDL cholesterol with the various medications and pharmaceuticals that were available. Well, the interesting thing was we saw a benefit. We saw the CVD mortality drop in both men and women significantly as a result of the total and LDL cholesterol levels dropping as well. But what's interesting is in 2010, the LDL went from about average U.S. population on average around 135 down to about 105, 109 milligrams per deciliter. And we saw a benefit in the CVD mortality reduction. However, since 2010, the LDL cholesterol has been remaining almost completely flat. But what's interesting is both mortality in men and women has now gone in the opposite direction. In fact, if we were to update this slide to 2024 numbers, likely both of these lines would be off the chart, meaning all of the good that we did, we've eliminated it. But what this is showing is something is actually new that's driving this disease. It's no longer necessarily linked to the amount of cholesterol you have. Something else is changing. And so as a result of that, Quest, we look at our data, we look at the patient population, we look at the changes, and we ask the question, what could be driving this? And as a result, we recognize it's a lot of things. And so what we've developed is what we call the cardiometabolic approach. And one of the nice things is we see a lot of organization and industries seemingly following a line in our footsteps, recognizing that we need to stop treating patients with certain disease states as silos and begin to appreciate the totality of their conditions and how it affects all multiple organ systems. So what you see on the screen is the Quest Diagnostics cardiometabolic approach, where we put the patient in the middle. And then your interaction as clinician with this patient, you understand a lot about their family history. You understand some of the clinical questions. You see what they're eating. You see their lifestyle habits, sleep, what all the various pieces of information you're gaining right there. If any and all of that information begins to push you into a concern for one of the organ systems that's listed here, and you test that individual for that particular concern and it tests positive, what that means is all of the other organ systems are now at risk. And a very easy and classic example to show that this is true is take a patient, unfortunately, who's been diagnosed with type 2 diabetes. That's an endocrine disorder with glycemic concern for sure. 7 in 10 of those individuals have non-alcoholic fatty liver disease. One of the leading organ systems that's also affected is chronic kidney disease with the kidneys. And then, of course, the leading cause of death for these individuals is cardiovascular disease. So you can appreciate how that one condition actually drives risk in all of these different buckets. But so does other conditions as well. And that's what we're going to be focusing on is when can we get in the game before there's significant clinical concern? And can we augment this patient's trajectory in such a way that we divert them away from not only type 2 diabetes, but cardiovascular disease, non-alcoholic fatty liver disease, and even chronic kidney disease? And the answer is yes. So at Quest, what we recognize as a national laboratory, we owe it to our provider population to help them with the testing they're already using, and then ask question, can we add something to what they're already using that will enhance the effectiveness or the ability to discriminate risk? And so, for example, hemoglobin A1C and the lipid profile are probably in the top 10 tests that are always ordered by providers all across the country. There's nothing new there. But the question becomes, can we add something to the hemoglobin A1C that improves our ability to predict risk? And the answer to that is yes, and that's called the Insulin Resistance Panel score, and we'll talk about that one. And then to the lipid profile, I told you since 2010, LDL cholesterol has remained pretty much flat all the way to 2024, yet cardiovascular mortality has gone in the opposite direction. Are there testing that helps us understand that phenomenon? And the answer to that is yes, and that's going to be apoB or apolipoprotein B, and we'll talk about that one in more detail as well. But I want to focus on this idea of what's normal. Why is A1C not helping us as much as we would like for it to? And then once we learn from that, I'll share with you the Insulin Resistance Panel score and how that test can be utilized to help this. This particular slide is just showing you, of course, the obvious. When you look at ischemic heart disease and you look at cardiovascular disease being on the left-hand side and ischemic heart disease being on the right-hand side, basically, as the hemoglobin A1C increases, what do you see? An increase in risk. Well, that makes perfect sense. But what I want you to pay attention to is the 2 bar graphs in the middle of each one of these segments. If your A1C is 5.0, your risk for cardiovascular mortality is the same as a patient whose A1C is 6.9. And likewise, on the other side of the screen, you can see it's almost identically the same story for ischemic heart disease. So how do we discriminate whose A1C of 5.0 is low risk versus high risk with using a hemoglobin A1C? We can't. And so, to take that picture just sort of another step further, there was a study done by Kaiser that looked at approximately 46,000 patients, and it just asked a simple question. If we look at someone's glucose, can we predict when these individuals, over a 6.5-year period, can we predict which individuals may actually be progressing towards type 2 diabetes? And what they found was quite remarkable. if you had a blood glucose of 85 milligrams per deciliter, you had a 6% chance for developing type 2 diabetes over 6.5 years. And as you incrementally increase that glucose from 85 to 86, the risk went from 6% to 12%. When you go from 86 to 87, 12 to 18, and et cetera. So by the time you hit a glucose of 90 to 94, you almost had a 50% chance for developing type 2 diabetes in 6.5 years. However, once you exceeded 95, the linear progression changed to a hyperbole, and it went up almost 233%. Again, here's a segment of the population whose all of their glucose values are less than 100, so we wouldn't see those as at risk. But how do we predict which one of these glucose abnormalities is one we need to be concerned about versus the ones that we don't have to be concerned about? And the way we can cut this Gordian knot is just to understand the disease that's actually driving all of this. It's not prediabetes, diabetes. The disease that's driving all of this is insulin resistance. And the reason why this is so important is prior to obesity and prediabetes and diabetes, insulin resistance can persist for 8 to 10 years. Meanwhile, while insulin resistance is present, what else is happening? This is where we see patients begin to present with neurological issues and complaining about brain fog, or even maybe scaling low on mild cognitive exams. We see patients, of course, diabetes risk, but we see a new onset hypertension, or we see a new onset dyslipidemia that's emerging. We see some weight gain. We see certain cancers, even heart disease, all in, especially non-alcoholic fatty liver disease. All of these are happening during the years of insulin resistance when glucose and A1C appear to be normal, meaning less than 100 for glucose and less than 5.6% for A1C. But this is the power of insulin resistance. The other thing that I need to make sure everyone is acutely aware of, this condition is 100% reversible. So, for example, when we look at the progression from healthy, normal individuals as they progress to type 2 diabetes, we know how to spot a pre-diabetic and a type 2 diabetic. When their glucose is over 100 or their A1C is 5.7% or greater, we know we're dealing with a patient who's in the category of prediabetes. But that's not the definition of prediabetes. The definition of prediabetes is a loss or a dysfunction of 1 to 30% of the pancreatic beta cells. And then by the time you hit new onset type 2 diabetes, you've lost anywhere from 30 to 50% of those very valuable, very precious pancreatic beta cells. So the condition that we need to be aiming the majority of our interventions, particularly lifestyle modification and improvement in all aspects of that patient's life, is the state of insulin resistance. Why? Because we haven't lost any beta cells in the pancreas. They're working harder to compensate. In fact, that's what's keeping the glucose and the A1C appearing normal, is we're having excess amounts of insulin being driven into the system to keep those values looking normal. And that's the problem, though, with relying on glucose and A1C to tell you if a patient is at risk for insulin resistant. They only move when we start to see the failure of our beta cells to secrete sufficient amounts of insulin to control those values. So you can appreciate why insulin resistance is such a lucrative spot. Because if we tackle insulin resistance, we get 100% beta cell retention, and we reverse all of the comorbidities that are being driven by the insulin resistance. For example, the liver disease, the kidney disease, the hypertension, the dyslipidemia, the weight gain, the certain neurological issues, all of those things drop as a result of curing and resolving insulin resistance. So what we developed at Quest was what we call the Insulin Resistance Panel score. This is a very, very powerful tool, and I need to go on record as to say this right now. Insulin assays, historically in the laboratory space, none of them are standardized. What that means is essentially is you could run one sample in 3 different labs that do 3 different insulin assays and literally get 3 different results, low, medium, and high results. That's problematic because if you used multiple labs, you can't compare one to the other. So what it boils down to is how can we improve our ability to find these patients with insulin resistance? And the way we can do that is at Quest, we worked with Dr. Gerald Reeven's laboratory at Stanford University to develop a method that standardizes insulin testing. But more importantly, not only does it identify who has risk, but we can grade or give it a degree or the scale of which they have insulin resistance. So what you see on the screen now is an example of that work, where by measuring functional intact insulin and C-peptide together, we're able to give a score between 1 and 100. Now you're able to quantify to a certain extent how much or the level of insulin resistance a patient may have. So as soon as your score breaks 33, you're in the category of impaired insulin sensitivity. And as you go from 33 towards 100, you're increasing the severity of that insulin resistance. Now, here's the difference. Between 33 and 100, a patient's A1C could remain 5.0% all the way across that line. And they could do that for a period of 5 to 8, up to 10 years. So this is an opportunity. By using this particular assay, you can get in front of insulin resistance, manage it numerically with a value to show patient that you're improving their insulin sensitivity. And so this is what the results look like from our laboratory. There's the intact insulin that's being measured at the top. There's the C-peptide, but again, it's that score that now gives you a quantifiable number that you can track over time to review and evaluate the success and or failure of that patient to adhere to certain lifestyle modifications, supplement, sport, or even pharmacotherapy if indicated. Now, what's also remarkable very quickly is this assay actually has a unique ability to predict patients with non-alcoholic fatty liver disease in the absence of diabetes. So what this study found was actually if the intact insulin was 10.5 or greater, or the score was 31 or greater, you had basically a positive predictive value of 80% of having non-alcoholic fatty liver disease as compared to nuclear magnetic resonance images of the liver. So it's predicting, non-alcoholic fatty liver disease. It's predicting the progression towards prediabetes, diabetes, obesity. A lot of things are happening during the insulin resistant years, but this is where lifestyle modifications have their greatest impact, is during the insulin resistant years. Now, the second part of this is of course, we recognize the profound effect that insulin resistance has on increasing someone's cardiometabolic as well as cardiovascular risk. And what it does is it has a profound effect on the concentration of particles that carry cholesterol in circulation. So what you see on your screen here is when at Quest Diagnostics or any laboratory, if you ask for a specimen to, sample to be measured and looking for the amount of cholesterol, in this case, LDL cholesterol, that's what we're doing in that beaker, is we can measure how much cholesterol is, or LDL cholesterol is in that sample. And in this particular example, you see 100 milligrams per deciliter. That's 20th percentile. That's the optimal level that a person should be at, given all of the various markers that predict risk. But here's the real issue. Remember, I told you since 2010, LDL cholesterol has remained flat, but cardiovascular mortality has gone in the wrong direction. Why? Well, insulin resistance has been going up, prediabetes, diabetes has been going up, and apoB levels have been going up. This example is showing you can package all of that 100 milligrams per deciliter cholesterol into 3 normal size apoB containing lipoproteins. When those go into circulation, the cardiovascular risk is low. Or you can package all of that 100 milligrams per deciliter of LDL cholesterol into a high concentration of apoB particles. And when that runs through the arteries, now you're increasing the atherosclerotic burden, and therefore you have a high-risk patient. Same amount of LDL cholesterol is in both examples, but a very different number of apoB particles, meaning the greater the apoB particles, the greater the cardiovascular risk. The leading driver of that is insulin resistance, prediabetes, diabetes, and the obesity epidemic that we see in this country. So now you can appreciate why it's not necessarily all about the amount of cholesterol. It really is more important to understand how many vehicles, how many particles are carrying that cholesterol in circulation in patients with high concentrations of apoB versus low concentration. Those patients with high concentrations are at increased risk for cardiovascular disease, even if their cholesterol is optimal or appears optimal. So at Quest, at our company, we've had the ability to develop a panel called the Metabolic Risk Panel that includes the lipid profile. But now you can say, okay, well, the lipid parameters look normal, but is the number of apoB carriers abnormal? If it is, this person's at increased risk for cardiovascular disease. And then number 2, if the patient has a normal hemoglobin A1C, what you really want to know is does this patient have insulin resistance? And so now all of this can be evaluated with one profile. And then, of course, now you can optimize the opportunity to intervene on that patient's behalf when the lifestyle modifications and therapeutic interventions have their greatest impact. So with that, I'll say thank you, and I will open it up for questions.
All right. Thank you, Kenneth. That was wonderful. We do have a few questions. The first question we have is, What are the absolute risk versus relative risk shown for those increased glucose levels?
Absolute versus relative risk for those increased with what?
With the increased glucose levels. So I think the
Glucose
slide
levels.
showing the fasting glucose, you were showing the
Yeah,
various in
yeah,
range.
yeah.
Yeah.
I don't. I unfortunately I don't believe I have the ARR and the RRR on those cohort, but I'll be more than happy to get it. But I will say this though. What I like about that particular study is they weren't out to prove, that glucose levels should be changed or that we need, which one could argue you might want to consider that. But what I liked about it was it's just at what point does glucose need to be before we see a behavioral change in the providers or the clinicians that are managing these patients? And when you have, for example, a patient with a 70 milligram per deciliter fasting blood glucose versus 99 milligram per deciliter fasting glucose, when those appear green on a report, if it doesn't, those are very different numbers. 1 point away from, pre-diabetic reference range versus 30 points away. If the provider doesn't see that as a possibility of risk and intervene, then they're missing the window of opportunity, greatest opportunity to intervene. Because once they trigger past, 100 milligrams per deciliter, there's a likelihood that there's beginning to see a loss of beta cell function. But I like the question, and it's a fair question to ask. But I think the study was more in line with at what point do we start to see changes, an increase in risk over a period of 6.5 years, and it's basically when blood glucose hit 85 milligrams per deciliter or higher.
Awesome. Thank you. All right. So the next
Mm-hmm.
question, can you use the HOMA-IR calculation to identify insulin resistance?
Yeah. So sure. You have, for example, you have triglyceride glucose index, you have HOMA-IR, you have triglyceride HDL ratio, and then you have the insulin resistance panel score. These are all, modalities or techniques that trying to get at who has insulin resistance and identify that earlier. So yes,
Okay.
but but the real issue, they characterized the insulin resistance panel score. They looked at triglyceride HDL ratio, and they actually also looked at HOMA-IR, and then asked the question: these three techniques compared to insulin suppression testing, which is the gold standard for diagnosing insulin resistance, but you can't do that in a clinical setting with great ease. Compared to that method, how well do these technologies stack up? So, for example, the insulin resistance panel score had an odds ratio of 6.9 with a p-value of 2 times 10 to the negative 11. Very
Mhm.
strong odds ratio and a very statistically significant p-value. The triglyceride HDL ratio, it had an odds ratio of 2.7 with a p-value greater than or less than 0.05. I can't remember the number right off the bat, but it achieved statistical significance.
Mhm.
However, the HOMA odds ratio was 1.5.
Mm.
Unfortunately, it didn't achieve statistical significance compared to the insulin suppression method. So it's if you like the idea of HOMA-IR, then it's just a matter of, that means you're thinking right. Then it's just a matter of, okay, well, what's the most accurate means, and that has the high statistical significance to help me with this? What's the most accurate modality I can use? And in this particular case, the insulin resistance panel score seems to be the strongest predictor of that particular condition.
Okay. That's good insight on like how those different
Any other?
scores are, actually giving us that
Mm-hmm.
information. So thank you for breaking that down. I think this next, I think you already kind of
Sure.
answered it. It was just like around the reference range for the fasting glucose. So I think we answered that one. Um, Next,
Okay.
how do you create the insulin resistance score? Is it a formula from the insulin intact and the C-peptide numbers?
So how to treat the insulin resistance panel score?
Or like how is the score developed? Like is it coming from those two values, the insulin intact
Oh,
and the C-peptide?
yes, that's right. Yeah, that's right. In other words, we're utilizing the insulin and C-peptide, and it's a fairly sophisticated formula, but it's published. You're welcome to see it and look at it. The problem is you can't just do a total insulin at any other laboratory and a regular C-peptide in your laboratory and use that formula. Because that formula, remember, the importance of insulin is what are you measuring exactly? And that's when we use the liquid chromatography tandem mass spec method to understand exactly how much intact only insulin there is. We get rid of all of the noise. So we're using a standardized method, and then we use C-peptide in that formula, and it generates that quantifiable score. So yes, it is in fact, what was interesting is insulin by itself and C-peptide by itself, they weren't very powerful, but the score is what actually pushed it out to the hazard ratio of 6.9 fold odds ratio with a 2.0 times 10 to the negative 11 p-value. By themselves, they didn't have the power. That was actually a surprise finding for us at Quest to see how well that test performed by using the two combined. So yeah, the power is in the actual number. There's value in the individual numbers, but the power is in the actual score of combining those two.
Nice. Okay. Next question. What are your thoughts on the benefits of using apoA and lipoprotein A?
Yeah. So APO, and I'm going to say this, if you like APO capital A1, apoA, that's the functional protein found on HDL, and then lipoprotein little a, that's the genetic lipoprotein, or the amount of lipoprotein that's formed based on your genetics. So if you like that data, yes, let me just go ahead and say yes. So right now, apoB is the total concentration of non-HDL particles in circulation. apoA1 or capital A1, that's the total concentration of that functional protein that's bound to HDL. So a lot of studies use the apoB-A1 ratio, and I'm all for that. But in the US, we're just now, in the last 5 years, really putting a lot of emphasis behind apoB. The problem is in the US, we always want a drug to treat something. And what do we do to raise apoA1 other than stop smoking, increase your exercise, lose the weight, all those wonderful things. So no issues with that. Now, Lp(a), on the other hand, 1 in 5 people in the world have it. And there's only one way to find out how you have it. You got to test for it, because if you have a high lipoprotein(a), you are, by virtue of having that elevation, at a greater increased risk for cardiovascular mortality than patients without it. Keeping all things the same. I'm a perfect example of that. My lipoprotein(a) is 360 nanomoles per liter. So I'm at a very high risk because I have a very wicked family history. So that means I have to treat all of my other global CVD risk factors much more aggressively to try to offset that genetic predisposition. I like the question, though.
Yeah, it's a good one. And thank you so much, Kenneth. And thank you all for attending and participating in today's session. We hope you found it valuable and gained some new insights. If we didn't get to your question, or you have a specific question about a report or test, please feel free to contact Quest Product Manager Andrew Hunt. As a quick reminder, the recording of the session will be sent to all attendees and registrants, and you can also access it in a few days at fullscript.com/webinars. We'll now take a 5-minute break before our next session. I do encourage you to join us for the second session, titled Redefining Risk, Combining Vessel Wall Pathology and Blood-Based Markers, presented by Dr. Derek De Silva. It's a fantastic follow-up to what we've covered so far. Thanks.